So welcome to unit exam. It goes by so quick. I'm always amazed how all of a sudden it's week 5. We're going to be doing that review over our information. It is chapters 21, 3, and 4. And that sounds like not much, but it is jam-packed with a lot of information. So let me try to break it down and let you know what this is about. Now, I want you to know that you have my daughter to be thankful for, because her entire life, she would ask me questions. And I had to break it down and simplify it. So I only had to answer it once. Or she kept saying, but why? But how? And when? And what do you do? And so because of that, I break it down and make it simple, but still give you that understanding of what you need. So first of all, let's go about and look at definitions. Now, definitions you're going to have everywhere. And if you don't understand the definitions of words, you can't apply it and you can't try to figure things out. So there's 2 things that have to do with inflammation of the brain. Meningitis. Meningitis is the covering of the brain and the whole spinal cord. And it is usually caused by, some really bad bacteria, right? But there are some viral meningitises. And believe it or not, all we do is treat it is Tylenol, Motrin, fluids, and rest. The bacterial meningitis gets the antibiotics and is the more dangerous of both of them. And we determine that by spinal tap, okay? Now, encephalitis is just what we call an inflammation of the brain. It's not as encompassing as meningitis. It's the whole thing, brain, spinal cord. Osteomyelitis is an infection of the bone. This occurs a lot. Kids step on something out in the yard, a rock, it punctures, and it creates, let's say in the foot, and it goes in and let's say it hits a toe. A lot of times it's actually feet and osteo on children or hands. And all of a sudden you're going to see big, red, swollen, painful, and the kid starts running a fever. And it usually is bacterial, and it requires some long-term antibiotics because it's gotten into the bone. Now, osteosarcoma is a bone tumor. Many times this is in the femur. A lot of times it's adolescents. And they have to remove actually the whole bone, which means the leg usually. And they're doing different treatments, trying to save the bottom of the leg and put it up, into the hip joint and take out the femur part. All different things are done with that. But we'll go into that another time. Ray's syndrome. What do we need to know about this? Well, Ray's syndrome is really something that can happen because we give aspirin. We should never give aspirin to a child. So if you hear a parent wants to give aspirin, no, we don't do it. There's only one condition we do that to, and we learn that in the cardiac chapter, which is week 6, and that's something called Kawasaki disease. And the aspirin is used because it thins the blood for the clots. That's the only thing it's good for. But besides that, we don't routinely give it. Ibuprofen can be started after an infant is 6 months old. Before that, just Tylenol. Now, sepsis, what is it? Well, it's an infection. And sepsis is when it goes everywhere. So you get an infection, it gets into the blood, okay? Whether it's bacterial, viral, fungal, and this infant child is sick. So it's systemic, it's everywhere. Sepsis, overwhelming sepsis. And that's one of the big causes of death in the children is that infection that we just can't cure, and it gets to that point. Now, conscious sedation is something that we use when you have a kid who, and this is how I've used it a lot, is, we get a child with a fractured radial and tibial bone, and we need to set it. And it's a little bit more than just morphine will take care of. And we want to be able to do it and send the kid home. So we do something called conscious sedation. And we give this medicine, but they still breathe by themselves. That means protective reflexes. They still maintain their airway and they still sort of know what's going on, but they don't remember a thing and they don't feel pain. And it's great. I usually tell them, think about your happy place. You know, whether it's on the basketball court, send me to the beach is what I always tell them. That's my happy place. But it requires just a little bit of recovery. The kid goes home. It's better than sending him to the OR, which is a big, cost and time. Clinical pathway is what we do. It's that plan of care. It tells you usually what we expect to see. Urinary tract infection symptoms. We're going to do a urine CNS. We're going to give this antibiotic. They're admitted. We're going to be following these blood tests and we'll send them home on this, whatever it is in that treatment plan. It's just what we expect we're going to do. They have a lot of that in the adult world, like with myocardial infarctions. That was probably one of the first ones they made. Now, an emancipated minor is a child that's under 18 years old, but has legal consent to sign for themselves. For whatever reason, they went to the court and they basically, they're on their own and they sign for themselves. Very important that you have the papers that show that if they're under 18. Remember, at 18, children can sign for their own consent and you have to ask the child who's 18 and alert, cognitively aware, if the parents can understand and listen to what the doctor's saying. I think that's a change of events for these parents sometimes. Now, you will have, again, some of your theorists on here. I just try to remember oral, anal, phallic, latency, genital. Now, I can do jingle-lingles in my mind to remember some of them. The one group of children which have the weirdest names of things to remember is school age. And I want you to know, school age will be on HESI. School age will be on your NCLEX. It always is. So I try to, stress those names to you. Now, oral, everything in the mouth, pacifier, that's your babies. Anal, potty training, toddlers. Phallic, which is about boys liking moms and moms liking girls type thing. The genital, it's when you go to the adolescent and now they're, interested in whoever their other sexual partner might be. And then of course, latency. Again, school age latency, what does that mean? Basically all it means is they like as their friends to be same sex. And that's just part of what Freud says. So again, this goes into the same thing, basically what I just said, all about it. You can read it a little bit more. Now, Piaget is all about thinking and figuring things out, basically, all right? So sensorimotor is 0 to 2, and it's all about figuring things out. It is understanding that I have a rattle. If I shake it, it makes noises. Or it also means if I take my sippy cup sitting at the high chair, mommy's in the kitchen and I want her, I throw something on the floor, that sippy cup, mom's gonna come. That's part of, figuring things out and getting what they want. And of course, this is the object permanence. Even though it's not in sight, we know we still have it. Pre-operational is starting that imagination. It's starting to use the arms like they're an airplane. It's starting to use a broom like it's a horsey. It's starting to figure things out, how things work. Now, concrete operational is more, they're understanding things more than other children, but they're not one to manipulate it to their favor yet. They know what they have to do or how things work, and they can explain it, but they're not able to like the formal operation, the adolescence, this is what I say about Piaget and formal. Formal is when mom says, no, you talked bad to me. You didn't do this. You're not going to your friend's house tomorrow night. And you're like, oh my God, but I gotta go, right? What can I do to please mom for her to change her mind? So I clean my room. I do the dishes. I take the garbage out. I went to school and I got an A on that test. I studied hard. But look, mom, I did all that. Can I go, please? And they figure out other ways to manipulate that situation. So again, here we go. Another thing about concrete operations is something what we call is, why did I get sick? They're now understanding because they went outside with wet hair and it was cold, and that's why I got sick. Or my dog died because he's old. They're starting to understand more, okay? It's part of that concrete. Why the word is concrete, again, I don't know. So here we are, all of the things. Again, I'm not going to go down them again, but you can understand the Eriksons. Now, Maslow. There was a question on the last exam on Maslow, and it was about a girl who was in PE and was in sports. What level of hierarchy of needs of Maslow was that? And it was esteem, because she felt good doing it, right? When you do, like if, let's say I cook well and bake cookies, well, I'm gonna make it for somebody that I want them to praise me so that I feel good about myself. The bottom level is what you need to live: food, sleep, shelter, clothing, that's it. And then it goes up from there. Then you need to be safety, you need to be loved, right? So those are those different levels, very simply. All right, Kohlberg, again, good and bad and a consequence for each, whether a good consequence or a bad consequence. Infants don't really understand, and toddlers, they don't really get this yet. They don't totally understand the good and the bad. But you start to get to preschool, they're starting to do things good because they want that praise. They're starting to get that. As they get into school age, they want to do things right. They don't want to do bad things. One of the questions was all about going to the convenience store and the other children stole candy. And this child didn't. Why not? It's because she didn't want to do bad. She didn't want to be punished for doing something bad. So that's Kohlberg. All right, let's go into orthopedics and the type of fractures and sprains, okay? Now, green stick is one side of the bone is broken, the other is bent. And you can see these on the x-ray. One looks crooked, and then you have a crack in one of them. Compound is the one where the bone comes through the skin. So if the bone comes through the skin, you're worried about infection because the skin is contaminants, right? As soon as it enters the atmosphere, you are going to need to be on IV antibiotics because infection, osteomyelitis, etc., will occur. Simple fracture, most common. You know, you fall down, what do? You put your hands out, fractured wrist. Most common of all of them. And a simple fracture, we need to put a cast on it. And depending on the age of the child, usually about 4 weeks, it will come off. Oblique fracture is just a complete break at an angle. It's like, here's your bone, it breaks it at an angle, and it's just a complete break. Spiral fracture is this twisting type of crunch. It's not a spiral, it's not a break. And if you see a spiral fracture, most likely it is child abuse. And remember, if the injury does not match what the parent or child says happened, suspect it. Because remember, our job as nurses is to protect our children in the pediatric world. We want to make sure that they're safe. And I have seen some horrible child abuse that you wouldn't imagine in your lifetime. Okay, and I'll be affected for life about it. Now, sprain and strain, they're different. A strain is when you use something over and over again and it causes pain and it swells. A sprain is when a ligament is torn. How many times I went up to spike a volleyball in high school and college, came down on my ankle and the whole side of my ankle, you could hear it just ripping. And of course, it's the blood, capillaries are, ripped, it bleeds, it swells, and it is probably worse than a fracture with pain. And then contusion. This is a bruise. Remember, don't think just a bruise is not a big deal. Remember that contusion goes underneath, can occlude blood vessels. So always, always, always check neurovascular signs. And if you see ever decreased pulses, you know there's some impairment, you need to call the doctor. Let the doctor know. These are those pictures of those things that I just talked about. You can look at them closer, it's your time, but I wanted you to have a good group of it. So things that can go wrong with bones. Now, remember scoliosis. Think of the S. This is this big S-shaped spine. You're going to see a child, one shoulder is higher and the scapula sticks out too. And then one of the arms look longer. We treat it with a brace, put some lotion underneath, to prevent that rubbing and keep that circulation going good. And then exercises usually is what we use for scoliosis. So it can be treated just medically, okay? Ewing sarcoma is in the bone marrow of long bones. It is a cancer and it requires, radiation, chemosurgery on that, so it is a long-term care to get rid of it if we can. Leg calf birth. And what that is, it's the bone and the development of that femur is not, developed the way it should. Usually it's a disruption of blood flow there. So that femur doesn't go correctly. Many times you're going to see this child limping, which makes you find out that's what it is. Usually it's just resting, and NSAIDs, can help, with that develop better. JIA is another word, or juvenile idiopathic arthritis is rheumatoid arthritis in children. They've changed the name to that. Remember, arthritis, this type of arthritis is all about the joints. So the body says, joints, I don't like you, attacks it, eats the joint sacs, makes it swollen, and it is painful, especially in the morning or when you're trying to get up after sitting long. I have RA, and I'm telling you, it can be very painful. There are types of it. We call oligoarthritis is 4 or less joints. And then you can have poly, which is you can have joints everywhere. I have my knees, I have my ankles, I have my fingers, I have my wrists, I have my elbows. So, I'm beyond poly, okay? I've already mentioned osteosarcoma, and it is, again, a cancer, and it has to be, usually it's the femur, and it's usually boys and adolescents. So it's not a good diagnosis for these adolescents, which already have issues. So it is a surgical thing after chemo. Duchenne muscular dystrophy. There's a lot of muscular dystrophies, but Duchenne is the one that's always tested upon, especially NCLEX in your HESI. Duchenne muscular dystrophy, which means the muscles become less and less able to do what they're supposed to do, as in progressive muscle degeneration. We usually see this in boys. Ages 3, all of a sudden, they're waddling more, they're falling more. they'll get weaker and weaker as they get older. And then you see these big, thick, overdeveloped or hypertrophic calf muscles on them. Usually these children, they need intensive physical occupational therapy. They usually end up in wheelchairs. And because it's progressive muscle degeneration, these children usually die in the adolescence because their heart's a muscle, it degenerates, right? And their diaphragm's a muscle. So it's usually cardiac and respiratory just stops working and they die. Now, torticollis is when your sternocleidomastoid muscle, oh, I love that word, sternocleidomastoid, say it 3 times quick. It's the muscle in the neck and your neck goes to the side. Many times you see this in newborns because the way they pull them out as they're born and the muscle gets stiff. And it just requires heat, maybe some Tylenol, but usually just heat and just exercise will get that back. Now, traction is used a bit with children, adults also, and traction basically stretches and holds something to where it should be. It stabilizes, realigns. It could be an arm, a leg. I've seen it in the neck too. There's different sort of tractions there. Now, the most common of all of these sort of tractions is what we call Buck's traction. And I've actually seen this even put on in the ER because of the benefit of it. Now, Buck's traction is on the lower leg. They take this thing, a boot, and nothing sticks in, nothing into the muscles or bones or anything. It's on the skin and it's attached by a boot, and they with Velcro get it tight, and it's hooked to a string which goes over a pulley onto a weight. Okay, you have to be straight in bed. You're going to need help for these children pulling them up in bed. You should never have that foot on the end of the bed because nothing's pulling it, because usually for Buck's traction is used for fractured femurs. What are fractured femurs? Are this bone, that big bone, in the upper leg, and it cracks. And when it cracks, there's these little tiny, little pointy things that get into the muscles and it gets into the nerves. And because it's a big muscle, it spasms. And and these little pointy things create a lot of pain. This Buck's traction straightens it and puts it in a better position until they can get to surgery. So you want that leg pulled. Nursing care, monitor neurovascular signs. Take a pedal pulse, right? Look at the toes, capillary refill. Is blood still getting there? Because this is the femur bone and all that swelling that could occlude blood flow, right? So keep it straight, not on the end of the bed, so it's pulling. And then as nurses, if they slip down, these children it could be up to 5 kilograms of weight. They can't pull themselves up or they'll hurt themselves. So pull them up in bed. So again, what does traction do? It immobilizes and straightens wherever this break is. I've seen it on humerus. I've seen it on femurs. It pulls it and it decreases that pain until surgery can be done. And it's almost instant these kids feel better because those big muscles are pulling it. And if it's allowed to pull, it's going to pull it tight. So nursing care, traction, watch for pain, check for pulses, look at the color, and then that numbness, does it feel good? And are they able to move it, right? So any one of these things that's not right, no pulse, the color's bad, it's numb, they can't move it, call the doctor. Now, this is the one that's used on the neck. And this is the skin traction. We do have the ones that have the metal and little pins into the scalp, all of those things. And what does it do? Well, I have seen in my career, 16-year-old boy slid into third base, his head hit the knee of the defender, and you heard a crack, okay? His cervical fifth and sixth spine should be straight. It was angled like a big V, okay? He had numbness complete on the right side and partial on the left when I got him. So you know you were this close to complete paralysis. And that high up, again, you're gonna work about breathing too, right? So what we did, I was the trauma nurse I was the primary, I was in charge. I made sure I kept that neck where it needed to be. We got him through an MRI, got him up to the ICU, and we attached those pins on that head and kept it pulled straight until we got the swelling down, and the next day he went to surgery. So the end of that story, 2 weeks later, I went to visit him upstairs. He had complete function with slight numbness on the right side, and he was going to go for inpatient therapy and then 1 year later, that kid walked in to hug me. He was perfect. Absolutely no residual. So nurses do make a difference. Now, cerebral palsy is a type of disorder that has to do with movements and muscle tone. It has to do with either there's some brain abnormality. I've seen a lot with hypoxic episodes at birth or after birth. And this is damage that occurs here. And what do you see with it? Well, you're going to see them. Their reflexes are not the way that they should be. They're just different. They'll be floppy or really rigid. Spastic cerebral palsy is the one that you see the kids and their arms and they're just really tight, right? Part of it. These abnormal movements, many of them can't walk. If they do, they're unsteady, and a lot of them are in wheelchairs or require walkers to move around. Now, what are those movements called? It's called aphostosis. That's those involuntary, purposeless movements. They sort of move and they don't know, or their hands twist and you know, they can't use them properly. As I said, spastic CP is when they're really tight and they're really moving. So aphostosis is involuntary movements, and spasticity is, where is it? Is it in the arms? Is it in the hands? Where is it? And that's that. Aphostosis, I can't pronounce that word, is when they arch their back. It's just part of it. And there's a picture of it there to let you know it's muscle contractions. So those three things you need to know about CP. All right, pain scales. Now, pain scales are, what do I use? When do I use it, right? Well, in pain scales, we have one that's used for infant and nonverbal. We have one that's used for children who can look at pictures and relate it to how they feel. And then, of course, older children and adults that have numeric from 0 to 10. You know, 0's nothing, 10's the worst. Well, FLAC is all about face, legs, activity, crying, and consolability. And you get a score of 0 to 2. And I've used it a lot, and actually it works really well. And you get a score. And then, according to what it is, do you give medicine, right? Now, this is for your infants and toddlers. At age 3, which is your faces, they can start to use it. And they can really tell you. They can point at number 6. I feel like that. They're really good at letting you know. So again, this is what students get it wrong all the time. At 3, it's faces. Below that is FLAC, and any nonverbal is FLAC. So the question, what is pain? Well, it's whatever they say it is. Okay, you cannot say, well, you don't look like you're an 8, you're sitting there laughing. Well, that might be the way the client tolerates it or deals with it, right? It is pain whenever and however they say it is. And that's according to the American Academy of Pediatrics. Vital signs, what is it? Well, it's the 5th vital sign. You know, JCH, the Joint Commission, came out with that. Now, when do you give certain medicines? Well, opioids are the ones that you're in a lot of pain, you know, especially freshly post-op pains, right? Pains that are a day or two older, surgery, it's not going to be that you need the opioids. You might be able to give something else, you know, instead of giving morphine or something like that. Maybe we could give some ibuprofen or Tylenol, because actually in children, it works well. Adults, maybe not as much, but children, absolutely. Acetaminophen works really good with children, you know, with earaches that are below 6 months. And it really takes the pain away. So just don't think, well, I'm only giving, you know, Tylenol. Well, it does work. In children, we're using a lot of lidocaine. And we do it for when we're going to stick them somewhere, whether it's for an IV, whether it's for sutures, reinserting a tooth that's fallen out. We use it. We also use lidocaine if we're going to do a spinal tap because it numbs the area where needles are going in. Okay, so the kid feels all the touch and they don't feel pain. So that's pretty cool, because in children, we try to be as pain-free as possible. Who knows what flumazenil is used for? What is Narcan used for?
Opioids.
Narcan is opioids. Flumazenil is your benzodiazepines. Your Versed, your Valium, your Ativan, any of your PAM, any of your PAMs, okay? Diazepam, lorazepam. Good. Okay, the kid in the hospital. You know, kids going to the hospital is quite a threatening experience for them, because now they're somewhere and they don't know what's going on. And they start getting upset and worried and freaking out immediately, okay? Just remember that. Kids don't like to be not in control. So when does discharging planning begin? As soon as you talk to them. Because, you know, you're trying to find out a history. And as you're finding out the history, you're actually starting planning their discharge. Now, you just did a discussion question about separation anxiety. Remember, it's 3 stages: protest, despair, denial, or detachment. And let me get you off. And we know that initially, what does a kid do? Mom has to go home, or she has to go to work. There's nothing she can do, and she has to leave the kid there alone for a period of time. And that kid is going to be crying, he's going to be screaming, and is going to be having quite a moment. And you need to expect that. You know, if that happens, I like the parents, please let me know you have to leave and let me be there. Tell me what comforts them, right? Is it a favorite toy? Is it a favorite pacifier? Is it maybe an apple juice if they can have it? Find out what's going on, and then you can help. But just know they do go through, I'm going to cry. Then they stop crying and they sort of, you know, go into this regression. And then they're like, mom comes in and I don't care if you're here, you haven't been here. So they sort of forget about mom. And they do. They go through those stages if they have to. How can you promote security when they're hospitalized? Well, number one is parents staying with them. That's the number one. But if they're not able to, it's that favorite whatever. Is it their favorite jammies, their favorite toy? Is it their favorite blankie? What is it? Make sure, especially you as nurses, know what that is. Another thing that we can do to help reduce this anxiety is to keep these kids on their same schedule. You know, if they wake up and eat breakfast right away, do that. And then if they get dressed in regular clothes, if they can, in the hospital, do that. Try to keep the diet the same as you can, if you can. Nap time, same time. Bath time, same time. And if you do that, the kid knows what's to expect, right? They know what's coming. They're not going to be worried about, so what am I going to happen next, right? Because this is different and I don't get it. Especially your toddlers. They're always, you know, the ones that really respond to this anxiety. Now, if you have a kid who has an altered state of consciousness, all of a sudden, these kids are not as alert as they were or not responding. You take a blood pressure and it's going to be low. Why would you have an altered state of consciousness with a low blood pressure? Not getting flow to the brain. Oxygen's not getting there the way it should. As simple as that, okay? So goals when caring for a hospital child, well, again, make sure the parents understand what's going on, okay? And let the kid knows what's happening. Explain everything, get down to their level. Don't ever stand above them, get down to their level. Explain it in a level developmentally that they understand. Also, if it is going to hurt, let them know, but say, it's going to hurt a little bit, but I'm going to give you medicine, which is going to help, and it's not going to hurt that much. You know, it's not going to hurt for long. So be honest, because if you say it's not going to hurt and it hurts, that kid will never trust you again, and you don't want that. Remember, all children are different. Some kids don't care about an injection. So kids who need a cast, some are like, okay, good, I want a yellow one. Another kid's like, I don't want to do this and wants to run down the hall. Remember, all the kids are different. In fact, this is why I love pediatrics so much, because they are different. Again, try to maintain the home routine and, you know, play is the best thing to get these kids through these experiences, this distraction. I used to love putting the radio on, walk into the room and start dancing like a crazy person, you know, and they get so like, what's going on here? And they start laughing and they forget they're in a hospital and they should be afraid, right? Okay, the eyeball. What can go wrong with the eye? Well, kids, anything can happen. Number one is an infection, and it's also called conjunctivitis or pink eye. That's when you have the goopy green, reddened, and extremely contagious, okay? Make sure children learn how to wash their hands, and you wear gloves. Another thing that we can see is hyperopia, which means farsighted, means I can't see here in front of me. Myopia is nearsighted, which means I can't see over there. Now, why they put those names backwards, I don't know. I've never figured it out, but it still mind boggles me. Now, there are some conditions. One is called amblyopia. One of the eyes is weak or maybe goes inwards, outwards, upwards, downwards, and the muscle doesn't work right. So how do you treat that? Well, it's a muscle, I said. How do you treat weak muscles? You exercise them. How do you exercise an eye? Cover the good one and let the bad eye look around and let the muscles work. Strabismus is when you look ahead and each eye looks at a different place, but they don't go to the same point. So they don't work. So your eyes are sort of trying to figure out how to focus. It also has to do with depth perception also. Now, nystagmus is the wiggling eyes. You'll see them wiggle back and forth. Again, this is the muscles going on. And then papilledema is the swelling of the optic nerve, which is going to cause some vision issues. Now the ear. How do you know that there's hearing loss? Believe it or not, hearing sometimes and the inability to hear well is first figured out because they're not speaking. Their speech is garbled. So you have a child who's not speaking clearly and they're 4 years old, you check their hearing first. So if you can't hear, you can't speak correctly. That's one of the things you see. So type of hearing loss. One is one you're born with, congenital. That makes sense, right? Probably an intrauterine infection. Sensorineural is when the cell, the hairs, the cell on the nerves are not working right. They're damaged. And then conductive, which is when it prevents sound from moving. Conduction, it moves forward, right? If you can't move forward or going into the middle ear, it's conductive. Makes sense. Now, children who are hearing impaired, it's really important that we have a way to communicate with them. So we need them to be looking at us face to face. Again, not above them, face to face, all right? And keep at their eye level and have them look at you. And you're not going to start yelling and screaming at these kids. You know, that doesn't make sense. You talk in short sentences clearly and not loud. You don't have to do that. An acute infection of the external ear, otitis externa. What is the middle ear? Otitis media. And how do we treat infections of the middle ear? Now, oral pharynx, anything in the mouth, and the ears are connected to it, there is bacteria, there's staph. Everybody, all the time, has staph. So as staph goes into the ears, it's a bacterial infection, and it requires antibiotics for at least a 10-day period of time. Seizures. Well, a seizure is all of a sudden somewhere in the brain it goes and it starts this uncontrolled electrical activity, and you're going to see twitching, movement, staring. It could be one side, both sides. It could be one arm, one leg. It could be all different. Abnormal, something's going on in their muscle tone. As in, seizures are not all alike. Now, we have some descriptions of them. Grand mal is everything, tonic, clonic, and usually tonic and clonic, you'll see them be incontinent, or even their bowels can be lose their control. Also, it's what they call postictal, or a period of confusion afterwards. They don't remember what happened, you know, and maybe they fall asleep. Now, petit mal is a very short one. It could be just, you know, the eyelids fluttering, you know, one of those things. But you don't have that loss of bladder, bowel, and you don't have that afterward type of confusion. Jacksonian is one area of the arm, leg, or face, and this patient, this child, understands what's going on, and they're watching themselves. Myoclonic or atonic, all of a sudden they have these jerking motions when they wake, and then they collapse. And about a minute later, they wake up and it's done, myoclonic. Status epilepticus. Well, think about asthmatic. I call it staticus asthmaticus, or status epilepticus. Status means it's going on forever. It just goes on and on and on. And this one describes it as 30 minutes or more. And I've already described postictal, and that's that sleep or that confusion after a seizure. So what causes the seizure? Well, a little bit of everything. You know, it goes from infection, a fever, drugs, you have epilepsy, it causes it, and also hypoglycemia, especially in your younger children, you see that. So you walk into a room and a kid is, you know, tonic, clonic, having a grand mal seizure. What is your job? Well, make sure you go in, put the side rolls up because they will roll out of bed. Check the bed. Make sure they don't have anything sharp or hard in there that they can hurt and cause lacerations and damage to themselves. Because, you know, kids always have something in their bed. Make sure that the parent knows a kid who's having these sort of seizures, that they wear some sort of identification, necklace, bracelet, whatever it is. Another thing parents don't understand is, you know, if a kid is sick and don't want their seizure medicines, is, oh, he's sick, you don't need it. Oh, yes, he does. He needs to be very compliant with the medication regime, and he needs to make sure with the follow-up and do those drug levels as we need it. You know, Dilantin, phenytoin, you need drug levels to make sure it is where it should be. And then if a kid with seizures wants to do things like going swimming, you don't want them alone. What if they have a seizure in the middle of the pool, the middle of the ocean, the middle of the lake? Guess what? They're going to drown. So make sure that they are supervised. So there are a lot of things about meds I did, and I will send you those worksheets, and I also will send you 2 reviews. One is for PN. I'll send you a worksheet that has 15 questions on it. It's basically 5 questions in an exam, very similar to what you'll see. Practice, 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 and all your answers are there. So you can go through and look at them. To let you know, anybody who needs help with math, I can teach you how to do math in about 20 minutes. That's all I need. I can show you how simple it is. So I wish you the best. I'll be sending out these recordings a little bit later tonight. And if you need anything, you just have to let me know. Because if you don't let me know, I don't know to help you. Okay? Any questions?
Oh, are we done?
That is it.
Wow.
I don't do anything forever. I get to the point, what you need.
You're the best.
Yeah.
You're the best.
Professor, will you be sending those math